Thank you for the opportunity to speak to you this morning. And Runcie asked me to talk about identifying and addressing drivers in overcoming ovarian cancer. Next slide. So I thought I would, since I was the first speaker of the day, orient us again. So we know that in 2023, there were about 19,710 cases of ovarian cancer in our country and about 13,270 deaths. This is the fifth leading cause of cancer death in women in the United States. And on the right-hand side, you can see the American Cancer Society. They put this out every year. And you can see that, unfortunately, ovarian cancer accounts for about 5% of all female cancer deaths. Next slide. And so why is ovarian cancer so dangerous? And I know that many of you already know this. It's because such a large proportion of women are diagnosed with advanced disease. And so you can see on the left side, the different stages of disease. It's very rare that we actually catch ovarian cancer in stage 1 disease when it's limited to the ovaries, stage 2 disease when it's in the ovaries and fallopian tubes, or even honestly in stage 3 disease when it's in the pelvis and in the lymph nodes. Oftentimes, it's much more disseminated in the abdomen and even in the liver and in the lining of the lungs. And you can see that when we look at kind of government statistics of 5-year survival, that if we could catch it early, it would be so much better. And so the talk for early detection and prevention is for another day, but please know that there are many, many individuals that are working hard to continue to push the bounds of really creating new strategies for prevention and early detection. Next slide. So Runcie asked me to talk about drivers of ovarian cancer, and I have to say it made me stop and think a little bit. So I knew that the audience was mostly going to be patients and those interested in ovarian cancer. And so, so I wanted to think about, like, what does it mean to be a driver of ovarian cancer? I think that for some patients, it means, like, why did I get ovarian cancer? What is it that caused me to get ovarian cancer? For those of us kind of that care for women with ovarian cancer, driver means what are the specific DNA changes in my tumor? What were the molecular drivers that took a normal cell and made it become cancer and made it become aggressive? And so we're going to talk a little bit about that. And so there's two questions once you think about the driver. And one is, if I know the driver of my cancer, does this information help me and my treatment for ovarian cancer? And the amazing thing is that I've been in practice for 25 years. And, 20 years ago, the answer would have been no. And I would say now it is increasingly, the answer is yes, that the information of what drives your tumor can really help in terms of developing a treatment for ovarian cancer. And then a second thing is, if I know the driver, does this information help my daughters, my sisters, my nieces to prevent ovarian cancer in them? And again, the answer is it may. And so in the next 20 minutes or so, I'm going to go through some of this information. Next slide. So I wanted to start by saying, in this topic of, like, what drives ovarian cancer, there are still many unknowns. It's definitely better than it was 25 years ago, but still some questions that we don't have all the answers to. Why did I get ovarian cancer? We probably can answer that in about 15% of women who we know have an inherited form of ovarian cancer. But for 80% of women with ovarian cancer, we can't really put our finger on why you have ovarian cancer. Could I have done something to prevent ovarian cancer? Can we pick it up early? Can we target ovarian cancer with new drugs? Even though we're closer to answers, there are still many unknowns. Next slide. So what has been a big driver in our progress of understanding ovarian cancer? So you may have heard of something called TCGA, or the Cancer Genome Atlas Project. And this is a really exciting project that the National Cancer Institute sponsored. It was in the early 2010s. It was published in 2011. And it was amazing because they studied about 500 ovarian cancers and did really kind of cutting edge at that time analysis of those 500 tumors. And they were able to look at the mutations and really study this. And so much of the information that I'm going to talk about today has come from the Cancer Genome Atlas Project. Next slide. So what I'm going to talk about today are the different types of ovarian cancer, because one of the biggest advances that we've made is that ovarian cancer actually isn't one disease, that we want you as a patient to be empowered with the information to know what type of ovarian cancer do I have and what are some characteristics of that ovarian cancer, because that is going to be important for your treatment. We're going to talk about high-grade serous ovarian cancer, which is the most common type of ovarian cancer, and we're going to talk about drivers of that cancer. We're going to talk about how knowing the drivers of ovarian cancer impacts treatment, and then we're going to end by how knowing the drivers of ovarian cancer may actually impact prevention or interception. So next slide. So first, there's different categories of ovarian cancer. And so I'm going to talk about the big picture first, which is your ovary is made up of 3 different types of cells. So it's made up of the eggs, and tumors that develop from the eggs are called germ cell tumors. These are rare tumors. So I would bet that most people on this webinar probably don't have a germ cell tumor. They're rare and quite specialized in terms of the management. Another rare type of ovarian cancer are sex cord stromal ovarian cancers, and those develop from the cells where your hormones are made. And so those types of tumors are called granulosa cell tumors, Sertoli Leydig cell tumors, sex cord tumor with annular tubules, Sertoli cell, or fibrosarcoma. And again, these tend to be rare type of cancers. Within these, you may know someone, or someone may be in the audience that has a granulosa cell tumor. The largest category are called epithelial ovarian cancers. And even within epithelial ovarian cancers, there are subtypes. And if I would guess that the majority of you have a type of an epithelial ovarian cancer. Oh, good. Someone on the call has a granulosa cell tumor. And so within the epithelial ovarian cancers, the most common is the serous or high-grade serous ovarian cancer. There are other subtypes: endometrioid, clear cell, and mucinous. And the amazing thing about this conference is that you are going to hear from individuals today who are going to talk about rare ovarian cancers. So we'll talk a little bit about some of the rare cancers, but you'll hear more throughout the whole day today. Next slide. So we're going to focus on epithelial ovarian cancers. And there really have been major advances in each subtype that impacts treatment. And so we really want to empower patients to know what subtype of ovarian cancer they have, and what is the new knowledge, and what are the treatments that are available. So I'm just going to take some time because I do think it's important to kind of run through. These are all epithelial ovarian cancers, and the first category is high-grade serous carcinoma, and about 70% of all epithelial ovarian cancers are high-grade serous. The precursor lesion, and we're going to talk about this in a minute, is actually not the ovary, but the fallopian tube. So it's almost like one of these mind-blowing things where we realize that even though we call it ovarian cancer, it started in the fallopian tube. We know that about 15% of women with high-grade serous ovarian cancer have a BRCA1 or BRCA2 mutation. But again, 85% of women don't have an inherited cause. We're going to talk about the common mutations. And we're going to talk about therapies that are being incorporated into the treatment of high-grade serous ovarian cancer. And then you may have heard of clear cell carcinoma or endometrioid carcinoma. I do believe that Dr. Fader is going to be talking later on today about some of these cancers. They occur about 10% of the time in epithelial ovarian cancers. And if you look at the genetic mutations, they're very different than the high-grade serous. So ARID1A, PIK3CA, beta-catenin, microsatellite instability, P10. So even though they started from the epithelium, either of the fallopian tube or the ovary, the kind of pathway is very different, and therefore the treatments are very different. And then I do know that there's going to be a talk on low-grade serous ovarian cancer, and that is different than high-grade serous ovarian cancer. It, from a molecular standpoint, from a driver standpoint, is very different. And these tend to have more KRAS or BRAF mutations. Oftentimes they develop from borderline tumors. And the treatment, again, is quite different. And finally, there's mucinous carcinomas. These are very rare, less than 5%. And again, have different types of molecular features. So empower yourself, and we can talk a little bit more, but ask your doctor to talk about your ovarian cancer and what are the molecular features of your tumor. Next slide. Okay, we're going to talk about high-grade serous ovarian cancer. The most common mutations are P53. So almost 100% of high-grade serous ovarian cancers have a P53 mutation. In addition to P53 mutation, about half of all of these cancers have what's called homologous recombination deficiency. And we're going to talk about that because that's important for treatment. And then chromosomal instability is another feature. So the question is P53 the driver? If 100% of these cancers have P53 mutations, is it a driver? And the answer is not exactly, which was surprising. And we're going to talk a little bit more about that. And then the other question is it druggable? And so P53 is not so druggable, but HRD, or homologous recombination deficiency, is targetable. And we are going to go through that. So next slide. So I mentioned before this concept that all along we've been calling everything ovarian cancer, but it turns out that in most cases of high-grade serous ovarian cancer, it started in the fallopian tube. And it starts at that very end of the fallopian tube. It literally looks like a chrysanthemum flower. And the goal of that fallopian tube is to catch the egg that comes out every month. And it has tons of epithelial cells that get shed oftentimes. And we know over a decade of studying this that if you look at the fallopian tubes, that oftentimes, if you look at normal here, the normal has no brown staining in the epithelium. But if you kind of look more carefully, you'll often see some of these brown stained epithelium, and that's called a P53 signature. And so we thought, oh boy, that must mean that those are early changes on the way to developing cancer. And we actually don't really know that, because we find that even when you look at normal fallopian tubes, that they'll have staining here and they don't have cancer. But this is kind of the pathway. So someone will have a P53 mutation, and then they'll have kind of this rounding up of like multiple cells, and that's called a precancer or a stick lesion, and that occurs right before cancer. So we really want to know, P53, we know, happens early on, and it happens in all cancers, but not everyone with a P53 signature is going to go on to get cancer. So what we need to do in the next decade is figure out what are the molecular changes that go from P53 signature to stick to invasive cancer. And that's part of a large initiative called the Precancer Atlas that is being planned right now. Next slide. Okay, so this is what I was talking before. Understanding the natural history of ovarian cancer is really, really important. And because if we can understand it, we can kind of intercept it. Next slide. You can click again. Okay, we talked about P53. There's nothing on this slide that you have to remember, except for the mutant P53 is common in cancer. Probably about half of all cancers have a mutant P53. The problem is that P53 is a critical protein in all of the cells of our body. And so why is that important? We don't want to turn off P53 with drugs because then our body wouldn't work. And so that's what makes it difficult to target. Mutant P53 works with lots of other proteins that are important for things that are crucial for kind of normal cell functioning. It is, they kind of call it like the general of the cell because it kind of oversees so many other factors. I was reading something and it says that a driver never works alone. And so P53 is one of the drivers, but it has lots of cofactors. Next slide. Okay, I want to spend the most time talking about homologous recombination deficiency, because if you have high-grade serous ovarian cancer, I want you to know if your tumor is HRD positive or HRD negative. We know that homologous recombination deficiency occurs in approximately half of all high-grade serous ovarian cancers. And just to give you some historical context, how did we even come up with homologous recombination? Well, we know that for a long time, we know that there was a small number of women who had an inherited form of ovarian cancer. And then around 1994, we identified BRCA1 and BRCA2 as the two genes that are responsible for inherited ovarian cancer. And then we studied those proteins and we said, what do those proteins do? And it turns out that, that those proteins help in DNA repair. So your DNA will have mistakes along the way, and that'll cause like double-stranded breaks. And you have a whole group of proteins that fix your DNA. And so BRCA1 and 2 is a normal BRCA1 and 2 is part of this repair pathway. And so, so we really learned what homologous recombination deficiency does. And I think I saw in the chat that someone has a PALB2 mutation, and that is also part of the pathway of homologous recombination deficiency. So next slide. Okay, so this is explaining what it is, what normal BRCA does.
Dr. Lou, can you hear us? Can you hear us, Dr. Lou?
Yeah.
Okay. For about a minute or so, you were frozen, so you may want to go back just a little bit.
Oh,
you were
okay,
frozen.
goodness.
Yes.
Okay.
Yes. Go ahead. We got you back now. Go ahead.
Okay. So I think it's okay to go on. Just wanted to show this is what homologous recombination deficiency is all about, and that BRCA, that your normal BRCA helps to fix these. Next slide. So the most important part I want to talk about is how the drivers of ovarian cancer impact treatment and prevention. Okay, so women who are diagnosed with high-grade serous ovarian cancer should have their tumors tested for HRD. So how is a doctor going to test for it? We're going to talk about that. It's important for you to know the result of your test. And why? It's because PARP inhibitors are now used in either frontline maintenance, platinum-sensitive recurrent disease maintenance, and also as a single agent for recurrent disease. And these are effective treatments, and especially for women who are HRD positive. And I saw in the chat, someone said that they were HRD negative, and half of all women with ovarian cancer are going to be HRD negative, and that's okay. There are emerging treatments for women who have HRD negative tumors as well. Next slide. Okay, who to test for HRD? We know that HRD is due to either a BRCA, PALB2, BRIP1, RAD51C, germline mutation, or because there's not a mistake in the germline, but in the tumor itself. So if you have ovarian cancer, if you have epithelial ovarian cancer, we want you to be tested for a panel of genes that are going to tell you if you have inherited cancer. And that will also be important to determine if you're HRD positive. Next slide. And this is just a testing paradigm because not all doctors are going to do it the same way. Some are just going to test your tumor and then test your germline. Some are going to test germline first and then tumor, and some are going to do both at the same time. Next slide. And I just want to kind of quickly show that there have been a number of studies that have shown why PARP inhibitors are so effective. So this was one of the very first studies, and I think Katie Moore is going to be talking tomorrow. But this showed that if you had a BRCA mutation, and you were put on PARP inhibitors for maintenance, that your progression-free survival was much, much better. And this was one of the critical studies. And there's been a 7-year follow-up study that has shown that this difference in progression-free survival is maintained. So really showing the long-term benefit, not of staying on PARP long-term, but the long-term benefit of using PARP in the upfront setting if you're BRCA positive. Next slide. And then we wanted to say, well, what about if you're not BRCA positive, but kind of a broader category of HRD? And so this was a study that looked at PARP inhibitors in combination with bevacizumab or Avastin, because sometimes women are already on Avastin with their carbotaxol. And this showed that, again, PARP maintenance with Bev maintenance resulted in progression-free survival. Go to the next slide. And this slide just shows if the first panel is if you're HRD positive, and it includes BRCA positive. And so the second slide is if you have your tumor be HRD positive, and the last is if you're HRD negative. And so basically it shows that when you see the graph separate, the lines separate, that means there's a big difference. And so if you're HRD positive, you're more likely to benefit. And I'm going to have you move forward. And we're almost done. And I'm going to go to the next slide after this. And again, it's the same concept. This was the PRIMA study that showed if you're HRD positive, you're going to benefit more. But even if you're HRD negative, or what we call HRP, that there still is a little bit of benefit if you use niraparib in the maintenance setting. And so this is where you want to talk to your doctor about whether, based on your HRD status, whether it's useful to go on PARP. Next slide. And this is, I just wanted to kind of say, what if my tumor is not HRD? Because this will happen to half of women, and we will call this either HR negative or HRP, HR proficient. And so basically the benefit ratio is not quite as favorable in the frontline maintenance setting, but there's lots of research ongoing. Can we actually morph an HRP tumor into an HRD tumor? And also, you may have other drivers of your tumor, including cyclin E, and there are strategies that are being developed for that. So I want to make sure that I finish quickly because I'm hitting time, but let's just go to the next slide. And just wanted to kind of end by saying that if you're HR proficient, that a small percentage of those who are HR proficient will have an inherited cause. And we talked about PALB2, someone had that. And so we want to make sure that we test you for a germline. Next slide. And then click again. And because whether it's PALB2 or BRCA, if you have that, we want your relatives to be tested because they can prevent ovarian cancer before it starts if we know that you're at increased risk. Next slide. And this is where kind of treatment and prevention converges, so that when you identify a mutation in a cancer patient, then the patient has treatment options that they can use, and family members can be tested as well. Next slide. And then this is what I was saying before, this concept of double prizes. You can, if you're a patient, you can use the PARP inhibitor. If you're an unaffected relative, you can take advantage of preventive measures. And then you can just click through. I think on my ending slide is next. Go ahead. And you can go to, well, let me just say, I want to thank, some of you may have participated in the Magenta study. This was a genetic testing study where we had participation from women in every state, and it's being published today. And at 11 o'clock, it's going to go off. It's going to be, the embargo is going to be off, but it's a big study for us, and it was in JAMA Oncology. So just thank you if you participated. And then last slide. Yep. In summary, know which type of ovarian cancer you have, understand the basics of your subtype. For high-grade serous ovarian cancer, get testing for BRCA1 and 2 and the other genes, know your HRD status, understand how HRD impacts your treatment. And if you have a germline mutation, let your family members know. And that's it. And I'm looking forward to listening to the other talks, and I will look at questions, and we look forward to answering them in the panel. Thank you so much.